All right. Thanks everyone for joining us for this week's rendition of Cardiology Grand Rounds. I'm Cooper Kersey, one of the third-year cardiology fellows, and I'll be co-presenting with Dr. Smith from the Department of Pathology. We are excited to be giving the first Clinicopathologic correlates Grand Rounds of this academic year. Neither of us have any financial disclosures related to this talk. The learning objectives are intentionally vague so that we don't give away the punchline of the cases. But our hope is that by the end of today's talk, everyone will be able to recognize the utility of endomyocardial biopsy and pathology when there's diagnostic equipoise. Secondly, to be able to identify pathologic and histologic features of the presented cardiac diseases. And finally, to correlate a patient's clinical course with the underlying pathology. For the outline, we'll go through three different cases. I'll present the case, and then Dr. Smith will take us through the pathology. Our first case is titled Tissue is the Issue, a non-ischemic cardiomyopathy. Secondly, we have What's Old is New Again, a post-infarction VSD, and we'll close with a stimulating case of methamphetamine-associated heart failure. So let's jump into the first case. Our patient in question is a 70-year-old. He has a history of multiple myeloma, permanent atrial fibrillation, and tachybrady syndrome that he had a pacemaker placed for, as well as a prior stroke, and he's referred to the cardiomyopathy clinic for a second opinion. He does note a slight decrease in his exertional tolerance over the last few months, but no overt heart failure symptoms. He denies any macroglossia or periorbital bruising, and he has no pulmonary symptoms. Just in terms of his past medical history, I went through most of it, but it's important to note that his stroke was in 2022, so after his diagnosis of AFib, while he was appropriately anticoagulated with apixaban, and that was treated with a thrombectomy, and he has minimal residual deficits. He has no family history of unexplained cardiomyopathy or unexplained early death. But his father had an MI in his 50s, and he has an older brother with heart disease that he's not entirely clear what type of heart disease it is. He was a pretty active guy up until his exertional tolerance declined. He used to play basketball and run, so this is definitely a change in his symptoms. His workup took place over many years, so here's a quick timeline of it. His MGUS, or he was initially diagnosed with MGUS in 2017, and that was monitored clinically. The following year, he was diagnosed with AFib. He was ordered for a rhythm monitor to really assess for rate control, and that picked up that he was actually profoundly bradycardic. And so as workup for this combined atrial arrhythmia and bradyarrhythmia, he underwent a cardiac MRI, which showed patchy LGE, and this raised the concern for an infiltrative cardiomyopathy. For some reason, his cardiomyopathy workup was paused in 2018, but in 2021, he underwent a bone marrow biopsy. It showed that his MGUS had transformed into full-on multiple myeloma, and so he was treated with chemotherapy. The same year, his cardiomyopathy workup was resumed. He had a PET scan. It showed FDG avidity, and he was treated with prednisone under the presumed diagnosis of cardiac sarcoidosis. He then had a repeat PET scan that showed, despite immunosuppression, he had continued FDG avidity on his PET scan. And so for this reason, he was referred to UW, to the cardiomyopathy clinic, for a second opinion. On exam and his clinic visit, he had a pretty normal exam. Interestingly, he did have elevated cardiac biomarkers. His BNP was 1,000, and his troponin I was 0.09. His SPEP showed an expected IgG lambda monoclonal spike, and his capital lambda free light chain ratio was 0.07, and he was anemic. Here's his echocardiogram from his clinic visit. It shows normal systolic function, mildly increased LV wall thickness. His interventricular septum measured 1.3 centimeters, as did his posterior wall. And you can see that his aortic valve is thickened, and his mitral valve leaflets are a little thickened as well. Here's a four-chamber view, just re-demonstrating his normal systolic function and mildly increased wall thickness. really all of his valves were mildly thickened, his tricuspid as well, and his aortic, mitral, and tricuspid valves all had mild to moderate regurgitation. Here's his strain imaging, which is interesting. It doesn't show so he had reduced global longitudinal strain or impaired global longitudinal strain at negative 15%. There isn't a classic apical sparing pattern to it, but I convinced myself, and I hope you all can convince yourselves that the apex is slightly spared compared to the base of the ventricle. And here's his cardiac MRI from 2018. In the two chamber here, there's LGE in the anterior wall, and then the short axis also shows patchy late gadolinium enhancement. His PET scan, this is not a talk on how to read PET scans, but I will just highlight this is the standard perfusion and FDG images. He did have perfusion defects in the apical inferior and inferolateral walls, as well as the mid to basal inferolateral wall. And he had FDG avidity here in the basal anterolateral wall, as well as mid inferolateral wall. So some FDG avidity despite immunosuppression. So to summarize, this patient is 70. He has multiple myeloma, permanent AFib, and Tachy-Brady syndrome, as well as impaired global longitudinal strain on echo and some suggestion of apical sparing with patchy LGE and FDG avidity. And so due to diagnostic uncertainty, he underwent an endomyocardial biopsy. And while I'm transitioning things over to Dr. Smith, if you're here in the room, chat with a neighbor, or if you're on Zoom, just have an internal debate about what the underlying cause of this patient's cardiomyopathy is. I think the highest on the differential at this point are AL amyloidosis, ATTR amyloidosis, cardiac sarcoidosis, or a genetic cardiomyopathy. Right.
Thank, thank you. So that's a good differential. This patient, clearly has the AL phenotype, right? He has myeloma, AL lambda monoclonal chain, but then he has another possibility as well, too, right? Cardiac sarcoidosis, or as you mentioned, ATTR, transthyretin type amyloidosis. That's very common in the heart, obviously. So the biopsy was done. We're looking at the biopsy here, and this is really the most abnormal feature that we found in the biopsy. There's essentially a patch about half a millimeter by a millimeter of this amorphous eosinophilic material that's infiltrating the interstitium. It's surrounding a few cardiomyocytes. And when we do a Congo red stain, we show that that material stains positive for Congo red. And then we do polarize this and look at that. And it shows this apple green birefringence. So you see some areas with some nice green color as well as a little bit of yellow. You spin your polarizer a little bit and all that sort of changes color and looks really pretty. So this is really a classic cardiac amyloidosis. We didn't see any evidence of sarcoidosis. There was no inflammation whatsoever. So what explains the FDG avidity, I think, is always a good discussion in a case like this. But a clear diagnosis of amyloidosis based on the clinical history, the top of the list would be a primary amyloidosis. He fits all the parameters for that. But we have to do typing. And so here we took that little, 1 by 0.5 millimeter piece of amyloid, dissected it out of the tissue, and then processed that, and then did mass spectrometry to identify the amyloid type. And you can see here that, even with that very, very small sample, we can determine that if you look at all the amyloidogenic proteins, the only one that we really found in this patient was transthyretin. So it's an ATTR type amyloidosis, despite the fact that everything was telling everyone. And in fact, in a pre-mass spectrometry era for typing amyloid, I think this patient would have just been written off as a primary amyloidosis, and no further treatment would have been dictated.
For those on Zoom, Dr. Nazar's face just lit up with enthusiasm and disbelief. So I similarly, when I was reading through this case, was left with, oh, and then he did undergo genetic testing as well, which showed no pathogenic mutations in ATTR. So he was diagnosed with wild type ATTR amyloidosis.
Scan, not that it's indicated now, but like
he did not, yeah. I think because uh, there was this like diagnostic inertia towards sarcoid, the biopsy would answer whether it was sarcoid or amyloid and what type of amyloid. But yeah, in the traditional algorithm for clinical concern of cardiac amyloidosis, he should have gotten a PYP scan.
6 things on the list. Somebody should have said maybe it's something else.
Yeah.
It's interesting it's wild type, but
yeah. So the two questions that this case left me with was why wasn't it AL amyloidosis? He had he had multiple myeloma, and seemed like from Occam's razor he should have had AL cardiac amyloidosis. And then why was the PET scan FDG avid? So I went to the literature to try to answer these two questions. But first, briefly touching on ATTR amyloidosis, the incidence is 17 per 100,000 people in the US, but this is likely low due to it being historically underdiagnosed. And in high risk subgroups, like older folks undergoing TAVR and patients who have diastolic dysfunction, the prevalence has been reported as high as 13 to 16%. There's two types of ATTR amyloidosis: wild type, which is non-genetic, which our patient had, and then hereditary ATTR, which has an autosomal dominant pattern of inheritance. It's usually due to one of three main mutations, and the age of onset is somewhat dependent upon which mutation you have, but patients tend to present earlier in their 60s and 70s. The cardiac manifestations, I think we're all familiar with the echo findings: increased LV wall thickness, biatrial enlargement, the panvalvulopathy, which our patient had, pericardial effusion, and decreased strain with apical sparing. You can get rhythm abnormalities, primarily AFib and AV block. And then the non-cardiac manifestations are kind of interesting and differ depending on what type of ATTR you have. In wild type, you tend to have more orthopedic issues like carpal tunnel syndrome and biceps tendon rupture and spinal stenosis, whereas hereditary ATTR comes along with more polyneuropathy and autonomic dysfunction. And so everyone loves a good diagnostic algorithm. This is a diagnostic algorithm from 2019 for when you suspect cardiac amyloidosis. And I thought it was interesting to highlight because it really proposes a very dichotomous workup based on the serum, the SPEP, UPEP, and free light chains. Where if you have an abnormality in those markers, you go down an AL pathway, and if those are normal, you go down an ATTR pathway. But clearly in our patient, this diagnostic algorithm would have failed because he had both a plasma cell dyscrasia and ATTR. Looking at in the pre-mass spec era, the diagnostic accuracy of these markers, it's actually not great. This is from a study out of Mayo in the Cleveland Clinic, where they had 140 patients with biopsy-proven amyloidosis that actually had been subtyped, and they then compared it. They looked at how accurate the SPEP, UPEP, and immunofixation were at predicting the subtype of or the type of amyloidosis between AL and ATTR. And SPEP, UPEP, and immunofixation was only 75% specific, and free light chains performed a little bit better, but were still only 90% specific. Another study, also out of Mayo, that had fewer biopsy samples, only about 60, reported a capital lambda ratio between 0.5 and 5 as having 100% specificity and sensitivity for ATTR. But remember, our patient's ratio was 0.07, which falls outside that range. And in the study, it falls into the range where he would have been classified as having AL lambda. So I think that 100% sensitivity and specificity is probably more a result of a small sample size, and that does not actually hold up in clinical practice. So all that to say, mass spec should be performed whenever there is a tissue sample. And this is a newer diagnostic algorithm out of the 2022 heart failure guidelines for suspected amyloidosis. And there's still an initial split based on the presence or absence of a monoclonal light chain, but there is, once you go down the AL pathway, there's a recommendation to consider heart or other biopsy. And then once you have tissue in the appendix, it recommends mass spec, and you can cross back over from the AL arm sort of into the ATTR arm. So I think this new algorithm, or this diagnostic algorithm that doesn't have a dichotomous approach is a little more nuanced and acknowledges that both ATTR amyloidosis and plasma cell dyscrasias are common, and patients can have both. And then in terms of the diagnostic accuracy of mass spec subtyping, it is more accurate than SPEP, UPEP, and free light chains, up to 98% specificity in one study and 94 in another. And why is it important to make the right diagnosis? Well, the treatments are incredibly divergent. You treat AL amyloidosis with chemotherapy and ATTR amyloidosis with historically only transthyretin stabilizers like tafamidis. Here's the Kaplan-Meier curve from the landmark tafamidis trial in 2018 showing a significant improvement in all-cause mortality. But more recently, there's some new therapeutic options available. The transthyretin silencers, which are actually RNA silencers, stopping the production of transthyretin in the liver, have historically only been used to treat polyneuropathy, but there's the results of the Helios B trial of vutrisiran was just presented at ESC for treatment of ATTR cardiomyopathy, and it showed a significant improvement in all-cause mortality regardless of background therapy. So 40% of patients in that trial were already taking tafamidis, and regardless of whether they were on tafamidis or not on therapy, vutrisiran was efficacious. So an exciting time in amyloid therapeutics. And then the last question was, why was the PET scan FDG avid? I think as a division, we all, due to work by Dr. Nazar and Dr. Stempin-Otero, understand that not all FDG avidity on PET is sarcoidosis. We've had grand rounds about genetic cardiomyopathies with FDG avidity. HCM can have FDG avidity. ARVC can be FDG avid. But in my illness script for cardiac amyloidosis, I had never thought of FDG avidity on PET. There isn't a ton about it in the literature. I found a case series of 5 patients who had a clinical suspicion for cardiac sarcoidosis, who had undergone PET scans for that reason and ultimately got biopsies and had biopsy-proven ATTR cardiac amyloidosis that had FDG avidity on PET scan. So it certainly occurs, but the mechanism is not fully borne out. The authors posited that maybe the amyloid deposition was somehow inflammatory to the myocardium. That was their best guess. And so another reminder that all that glitters on PET scan is not cardiac sarcoidosis. Back to our patient. He was started on tafamidis. This is kind of a win because his cardiac amyloidosis was detected very early. He really had no clinical heart failure. AFib was his only cardiac manifestation. And so now he feels great still and does not have heart failure symptoms. Take-home points from case 1. ATTR amyloidosis is common and plasma cell dyscrasias are common, so patients can have both. Mass spec subtyping of amyloid is highly sensitive and specific and should be performed on all biopsies. And cardiac amyloidosis can be FDG avid on PET scan, and we're not entirely sure why. Questions about case 1?
This brings up the whole scenario. of this gentleman's course. And with all of with all the things that were going on at the time, if you get a test for something that's not, the false positive test problem. And so I'm not sure why they went that route, thinking giving this guy more than one disease, essentially, why they didn't do the pyrophosphate scan to begin with. It's just interesting. That might explain why this turned out like it did, because you did the wrong test to start with and you went down a wrong pathway. I don't know. Other thoughts?
Yeah, I think even the initial cardiac MRI was working up AFib and slow ventricular response, which I mean, lots of cardiomyopathies can present with arrhythmias, but that wasn't a slam dunk for sarcoid in my mind. So
I would have been Occam razored on AL amyloidosis, and I obviously was. That's why I said wow. In the case series you found of TTR with FDG avidity, did any of those 5 patients get biopsied in that study?
they all got biopsied.
Did any of them have inflammatory infiltrates?
I do not remember.
And ours didn't either, right?
Yeah.
Yeah.
Really interesting. Congo red's always been the sort of the pathologic biomarker of amyloidosis. Does anybody use that as a scanning agent in 5 patients?
I don't know. Can anyone else answer that question? I can't answer that one. Yeah. I was just going to say, from a perspective standpoint, I've looked at our heart biopsies for amyloid that we've typed here. We've done about 40 of those. 25% are primary, 75% have been ATTR. If you look at individuals that have had a monoclonal gammopathy, about half are ATTR, a little bit more, and about half are primary. So there's a really high probability if somebody has cardiac amyloidosis, it's going to be ATTR. And so I think you should always really keep that in your back pocket when you're working it up and say, it's really, if you're thinking cardiac amyloidosis, it's exclude ATTR because that is most likely what you're going to be dealing with, even if they have a monoclonal gammopathy.
What's the normal kappa lambda ratio?
It's like 0.26 to
5
or
2.
Okay. How?
Yeah.
Basically, you shouldn't have a lot more of either one, so it shouldn't be really high or really low.
0.26. And then the TTR can still have you said 0.5. What was the range in TTR you can see?
It was 0.5 to 5. Anything, basically not a lot of either kappa or lambda.
And I would, with our, if you look at the individuals with monoclonal gammopathy, we definitely have people that fall outside of that range. So it really, it worked well with that patient population, but if you now take that information and apply it to the general population, it falls apart.
Well, it goes back to the problem you presented, and that is 100% sensitivity or specificity in any test should raise a big question mark, because that, in my mind, doesn't exist. But anyway.
All right. Thanks for the questions and comments. Moving on to case 2, sort of changing gears. We have what's old is new again, a post-infarction VSD. This patient is a bit younger. He's 60, has hypertension, diabetes. He presents to Evergreen Hospital with chest pain and is found to have an anterior STEMI. After revascularization with a little more thorough history taking, it turns out that he'd been having intermittent epigastric pain for a month, that he'd been treating with Tums with no relief of said epigastric pain, and he'd had one really intense episode of epigastric pain a week before presentation that woke him from sleep, which was probably an initial ischemic event. No family history of early MI. He lives on his own. No family members in Seattle, but he does have a close friend. And no toxic habits. Here's his EKG from presentation, clear anterior STEMI. Notably, there are Q waves in V2 and V3, suggesting some chronicity to the process. And so he gets an angiogram, which shows his LAD is fairly diffusely diseased, but the culprit lesion's in the mid LAD, and it's treated with PCI. So a life saved, everyone feels great. And then on his post revascularization echo, here's in the 2-chamber, you can see his EF is mildly down. He has LAD wall motion abnormalities and an apical thrombus. Similar LAD wall motion abnormalities demonstrated in the 4-chamber view. And the sonographer notices a defect of the distal anteroseptum and interrogates it with color Doppler, and you see a large VSD with left to right flow. So for that reason, he was transferred to the UW Montlake for a higher level of care. He gets a CT scan on arrival, redemonstrating his post-infarction VSD. You can see some contrast going across the septum there, and also redemonstrating the apical thrombus. And when he gets here, he's actually fairly well. He gets a right heart cath, which shows largely normal RA pressure, mildly elevated pulmonary pressures, mildly elevated wedge, and a mildly reduced cardiac index by Fick. On his invasive hemodynamics, you can tell that the QPQS, the shunt, left to right shunt is very significant with a QPQS of 2.8, but he's not requiring any inotropes. He's not on pressors. He was in the CCU. He was like walking the halls, asking if he could be discharged. He felt great. So all the appropriate services are consulted, and discussions are had about what the correct way to treat his VSD is. And then while this discussion is happening, there's a day where his PA pressures acutely increase, and so he has a balloon pump placed to unload his LV and theoretically decrease some of that left to right shunt. This question, there's not necessarily a right answer. There might be a wrong answer. But while I'm transitioning over to Dr. Smith, chat with your neighbor about whether you think this VSD should be closed percutaneously, surgically, transplant. Don't be swayed by the fact that we're about to present pathology, or continued surveillance.
Right. So depending on what service this individual came to, it could be one of two of those answers, I think. So the patient did undergo transplantation, and this is the explanted heart from the individual. What I'm showing you is this is the what's left of the atria and the basal part of the heart, and then here are some of the sections, the cross sections. And so here you can see down at the apex, and we're moving up, and you can now see this area that looks darker. So this is a large infarct. It's a rather recent infarct. That dark color is just the color of blood after it's been fixed in formalin. You can see that it's really quite thin right here as well, and a fairly large infarct. And now as you get closer to the base, you can see that the interventricular septum here is extraordinarily thin. And you can actually, you wonder if it's even, existing in some places. Similarly here, if we look at the base, we can see some areas here where it looks like there might be some sort of tracks that have maybe undergone some endothelialization that are now leading from the left to the right. And here I just blew up some of those pictures so we could see those a little bit more readily. And this is sort of like if you're opening a book, those two pieces would be, you could lay those two pieces on top of each other. And we see here that we have this sort of open channel here that's then leading into the right ventricle from the left. So here's sort of an anatomic picture of the VSD, and then you can see this very large infarct. So we have this really abnormal appearing tissue here, a lot of hemorrhage and pale discoloration, and then some more normal appearing myocardium over here. So then this patient had significant coronary artery disease. This is an example of the LAD where we see just massive atherosclerosis, massive intimal thickening. We have lipid, cholesterol class foam cells, everything you'd expect. their LED, as was shown, is predominantly stenosed, and then there was also stenosis in all the other vessels, a really bad disease. Interestingly, given the patient's history, there was a large areas of remote infarction too. So this is well organized scar tissue. And here we can see some subendocardial sparing and then a little bit of expansion and fibrosis of the endocardium. And so this is an older infarct. It's something that's been around for several weeks at least, if not longer. So definitely this patient has had a prior myocardial infarction. Here's a little bit closer picture of that area of subendocardial sparing. And so you can see that this is this little strip of endocardium that's now going to get nutrients and oxygen from the ventricle, and that's spared. If you look at these cardiomyocytes, they're not very healthy. They have some vacuolization, so they're not really getting as much oxygen and nutrients as they would really like. And then in the fibrous tissue, we can see these areas with all these lipofuscin-laden macrophages, and those are the ones that have essentially feasted on and cleaned up the cardiomyocytes after the infarct. So in addition to the remote infarct, there's this acute infarct where we have these red areas, which are essentially dead myocardium with hemorrhage. Adjacent to that, we have granulation tissue, and then we have some cardiomyocytes as well. So there's the area of recent infarction. We can see these just dead islands of myocardium, granulation tissue, and then adjacent cardiomyocytes. And so you can imagine that the actual physical strength of tissue like that has just a ton of necrosis, granulation tissue is not that great, and that is definitely a predisposing factor.
All right, thanks for going through the pathology. So post-infarction VSDs, this data here is from a Medicare claims study looking at the prevalence of post-infarction VSDs over about 15 years, and it showed a 40% decrease in prevalence over that time period. But I do think here at UW, we're in sort of a unique position where our catchment area includes a lot of rural areas where folks don't have as ready access to PCI or thrombolysis. And so we do actually see a significant number of post-infarction VSDs, definitely on the CCU service here. So I thought it would be reasonable to review. And the studies on when to intervene are all limited by survival bias. Basically, the more likely you are to, the longer you survive, the more likely you are to survive. But this figure here is from a review article that I thought was nice because it gives a timeline with all of the main post-infarction VSD trials. So to point out a few, that STS trial here was all surgical repair, that Thiel et al. Was all percutaneous closure, and Gusto 1 was also surgery. And you can see that in each of the trials, sicker patients were intervened upon earlier, and so they had a higher 30-day mortality, as high as 60% in the STS trial, and 88% in the percutaneous trial. But if patients are able to survive, that mortality goes down. For the surgical trial, it went down to 50% if you can survive past 24 hours, 30% if you survive past a week, and mortality was only 10% if you can make it to elective surgery at 3 weeks. Probably the only wrong thing to do is to do nothing, because if no attempt at closure is made, by day 30, almost all patients die. So this has kind of influenced the paradigm of, as we saw from the pathology, immediately post-infarct, you have really necrotic tissue. It's incredibly hard. I don't suture into myocardium, but imagine it's very hard to suture into to perform a surgical repair. Similarly, for transcatheter repair, you need an appropriate rim to land a closure device in, and that tissue making up that rim is necrotic. And so the standard paradigm has been to wait until that tissue fibroses and then perform closure. In terms of how to intervene, this is that same Medicare study. Surgery was the only option up until the early 2000s, and then with advancements in transcatheter therapies, percutaneous closure became an option, but surgical repair remains more common. The only trial I found, or not trial, but only study I found comparing the two head to head came out of the UK and their robust national healthcare system data. They looked at about 300 patients who'd had post-MI VSD, 130 of whom had percutaneous closure, 230 who had surgical closure. They showed, and the surgical group tended to be a little sicker overall. More of them were in shock. The percutaneous group tended to be older because they had to have some reason that they weren't surgical candidates, and age was the main one. And the study showed that there was, here's the Kaplan-Meier curve with surgery in red and percutaneous closure in blue. There was an improved in-hospital mortality with surgical closure, but the long-term mortality was the same between the two groups. Yeah, either strategy is feasible and reasonable. And so that brings up the question, why don't we just take out the heart altogether? That would remove the ischemic or post-infarct VSD. There is a case series of 17 patients who underwent this strategy. All of them were in cardiogenic shock, requiring MCS. 8 of them underwent transplant as the primary strategy. 4 underwent transplant as a bailout after failed closure, and then 5 unfortunately died while awaiting transplant. Everyone who underwent transplant survived a hospital discharge, and there's long-term follow-up data for 6 of those folks, and they're all doing well. So I think this shows that outcomes after transplant at a high volume center are good. You can transplant patients with post-infarct VSDs and they do well. You do run the risk, since hearts can't be pulled off the shelf like a VSD occluder can, that a patient might spend too long on the wait list and get to that point of no return where the shunt has caused significant derangements in their pulmonary vasculature. But certainly a feasible strategy. Back to our patient, he was transplanted. He did well. He had an AKI post-transplant, required some diuresis, but he was seen in clinic last week and is doing really well overall. So take-home points for case 2. Post-infarction VSDs are not a relic of the past, especially at UW. The decision of when and how to intervene on a post-infarction VSD is challenging, and cardiac transplantation is a feasible strategy to treat a post-infarction VSD. I think we've got maybe 2 minutes for questions or comments before moving on to the last case.
Can you just say a little bit more about the decision to go to transplant? I would imagine that VSD was too big and too distal to close percutaneously, but I'd imagine there was a lot of nuance in those 9 days of what to do.
Yeah, I was not clinically involved in the case. Dr. Tice, who's in the back, was.
Yeah, it was a puzzle because he looked so well. In discussions with the surgeons, they thought his anatomy would not be really great for surgical closure, and that even if best case scenario they were able to sew and put something there, he'd be left with a pretty sizable infarct with pretty significant residual LV dysfunction, and then given the nature of where his defect was, percutaneous closure was not thought to be a perfect solution. As we see in the data, it rarely ever is a perfect solution. And so given that he was so well, he had such preserved end organ function despite some rising PA pressures, that it thought he really had a great pathway to potentially go into a transplant a little bit less sick than a crashing, burning shock patient. And we were able to get him there fairly well.
And it was like a couple of weeks. I mean,
hospital day 15. Yeah.
In the interest of time, I'm just going to move on to the last case. So we have a case of methamphetamine-associated heart failure. Our patient for this case is much younger. He's 39. He has a history of methamphetamine use that has led to a dilated non-ischemic cardiomyopathy and HFrEF. He's on home inotropes, and he unfortunately suffers an out-of-hospital cardiac arrest due to ventricular fibrillation. He gets bystander CPR and ROSC after one shock. He had recently been admitted for decompensated heart failure and actually presented for transplant and deemed to not be a transplant candidate due to his ongoing substance use. And so that was from that hospitalization, he was discharged on home inotropes with a wearable defibrillator, which he was unfortunately not wearing at the time of his arrest. His past medical history is notable for other substance use disorders, including alcohol, opiates, and tobacco. No significant family history, and he lives with his brother. When he arrived at UW, he was quite unwell. He was intubated. He was tachycardic. His extremities were cool. He had evidence of end organ dysfunction, an AKI, elevated cardiac biomarkers, elevated lactate, and elevated liver enzymes. So he went to the cath lab for a right heart cath, which showed pretty severely elevated biventricular filling pressures, severely decreased cardiac index at 1.4, and a cardiac power index of 0.52. His RV function was not perfect, but relatively preserved with a PAPI of 1.4. So he had a balloon pump placed and milrinone was added in addition to his home dobutamine. He also continued to have salvos of NSVT, and so he was already on amiodarone, but had lidocaine initiated as well. He unfortunately arrested overnight, requiring another defibrillation and CPR, and so a shock call was initiated, and he was cannulated for VA ECMO. Here is his echo pre-ECMO, just to demonstrate he has a severely dilated LV with severely reduced function. He has some functional MR and then a short axis view just to redemonstrate that his heart is not functioning appropriately. Here's his hospital course. We already went through day 0 where he had his balloon pump placed, day 1 where he arrested. He then starts to do a little bit better. He's extubated. He does continue to have VT requiring shocks, but no CPR. He's again presented for transplant and turned down due to active substance use. And then he clinically starts to get a little bit better. He has more pulsatility on ECMO. He has a pulse pressure of 30. So he's actually decannulated from VA ECMO and has a Impella 5.5 implanted surgically. But he is just unable to be weaned from univentricular support. He's on like P8 or P9 on the Impella and really decompensates anytime the amount of support is dropped. So he has an LVAD implanted on hospital day 13. He has a few post-op complications, but is ultimately discharged home a month after his cardiac arrest. And he signs a substance use agreement, basically saying that he'll abstain from substances, and he engages with Dr. Azen and addiction medicine really regularly in the outpatient setting. He saw her as frequently as every 2 weeks and had urine tox screens every 2 to 3 weeks and phosphatidylethanol levels to show that he wasn't using alcohol every month. He comes into VAD clinic. His INR is always therapeutic. He unfortunately develops a driveline infection, but otherwise things are going great with his LVAD. He does get an outpatient right heart cath, which shows that the LVAD has unloaded his LV to some degree. His wedge pressure is normal now, but he still has a low cardiac index at 1.8. And here is evidence of what ended up being 10 months total of abstinence from substances, aside from Tylenol, and his phosphatidylethanol levels were negative as well. So really an incredible job on Dr. Azen's part and the patient's part engaging with addiction medicine and abstaining from using substances. And so now our final question is, this patient is 10 months out from their LVAD. He does not have signs of myocardial recovery from his outpatient right heart cath. Is this patient a transplant candidate? at the UW. Again, don't be swayed by the fact that we're about to present pathology. So chat about this for a minute, and I will hand it over to Dr. Smith. Oops.
Okay, so transplant was the answer. This is some cross sections of the patient's heart, and in contrast to the last case, it's fairly remarkable for how well preserved the muscle is. The one notable gross finding is the dilated left ventricle that was seen with imaging studies as well. But really the muscle, at least at a gross level, looks really well preserved. And then this is probably the most abnormal gross finding. If you look at the base of the heart by the aortic outflow tract, there's a lot of endocardial fibrosis here. So this pale white staining material, or not staining, but the pale white material is the thickened endocardium. So there's a lot of endocardial fibrosis. You can see a little bit of discolored endocardium down lower that's a little bit more normal in appearance. And then if you can get a gander at this papillary muscle here, you can see this rind of fibrosis really that's covering that papillary muscle. So there is definitely some abnormalities here. There's a lot of endocardial fibrosis. And mostly towards the aortic outflow tract, at least in the left ventricle. Now, looking at low power, it's really pretty benign looking. It looks like there's a lot of muscle here, and that's always one of the things that sort of perplexed me. You see a lot of muscle, but clearly this patient's heart wasn't working. So how can what's going on to cause so much dysfunction? There's a little bit of areas here where we see a little bit more of light pink material, and maybe a little bit here, so that it's not entirely normal. And if we look at those areas on higher, we just see these little focal areas of interstitial fibrosis that are present in the myocardium. And then over here is another area that we see a little bit more frequently, and it's this area just of this pericellular fibrosis. So you can see that the cardiomyocytes are spread out, and there's this fibrous connective tissue that's interspersed in between the cardiomyocytes. So it's a really fairly subtle pathology that has a fairly substantial physiological abnormality associated with it. It's not just the left ventricle. If we look at the right ventricle, we see the same thing. And it's really sort of this fairly subtle change where we see this a little bit more pink tissue, a little bit more fibrosis. Look at it at higher power, really that same sort of pattern. So this pericellular fibrosis that's causing this abnormality. So there's no coronary artery disease. It was really just that finding, essentially.
Great. So I'll wrap up with a review of methamphetamine-associated heart failure. I'm not going to review all of the epidemiology and pathophysiology since Dr. Hidano, our former co-fellow and current faculty member at Harborview, gave such a fantastic grand rounds on this last spring. I would direct you all to the video of her grand rounds. But suffice it to say, methamphetamine-associated heart failure is on the rise. This graph here on the left is from the National Inpatient Database that and this is showing the number of admissions for people who use methamphetamine that is attributed to methamphetamine-associated heart failure. And there's been an over 200% rise in those heart failure-related admissions over the last decade. And furthermore, there's a geographic difference in patterns of drug use. And so as a result, there are regional variations in the prevalence of methamphetamine-associated heart failure. And in the Pacific Northwest, we have a very high prevalence. The reason I was curious what the pathology would look like for this case is one of the early landmark studies on methamphetamine-associated heart failure actually had endomyocardial biopsies for every patient. It's a study out of Germany from 2017, and they had 30 patients with methamphetamine-associated heart failure who they did endomyocardial biopsies on at baseline, followed clinically with echoes and clinic visits, and then did a repeat endomyocardial biopsy. And they showed that the extent of fibrosis on biopsy did correlate with the ability to recover LV function. This graph here in the top panel, they graded the fibrosis as either mild, moderate, or severe. On the left bar graph here is for patients who stopped using methamphetamine, and you see they have a much most of them have mild to moderate fibrosis, whereas people who continued to use methamphetamine have predominantly severe fibrosis. And the same is true of myocyte damage here in panel D. Since they had serial echo data, they showed that similarly, methamphetamine cessation leads to recovery of LVEF. This is the group that stopped using methamphetamine, and you see a trend towards EF recovery and a decrease in LV end diastolic diameter, whereas with continued use, you have either a flat line or a decrement in LVEF and an increase in LV size. And again, the ability to recover EF was independently associated with the degree of fibrosis. So interesting to see, since our patient did not have myocardial recovery, I was sort of expecting to see a more severe fibrosis on the biopsy. So it was interesting to see that it was not quite as severe. And then touching on the clinical management of this patient, the backbone of the management of methamphetamine-associated heart failure is cessation of methamphetamine and guideline-directed medical therapy. But we do run into this clinical scenario not too infrequently where a patient has end-stage disease, refractory to medical therapy, and the question comes up of how do we treat end-stage methamphetamine-associated heart failure. I would say there's 4 pathways or 4 options. Home inotropes, which our patient started on. There's a case series of 3 patients with methamphetamine-associated heart failure who were discharged on home inotropes, one of whom ended up getting a durable LVAD, 2 of whom were eventually weaned off of inotropes when they had some recovery of LV function with meth cessation. So that's an option. LVAD is a bridge to recovery. There's another case series of 2 patients who had very low EFs, about 10%, but they had no LGE on cardiac MRIs. So, LGE being a surrogate of fibrosis, they likely did not have much fibrosis, and this was a more acute process as opposed to chronic. And these patients had LVADs implanted. They recovered LV function and eventually had the LVADs explanted. So that is a possibility. Durable LVAD is an option, and then what it was historically maybe called LVAD as a bridge to candidacy, what I've renamed LVAD as a bridge to opportunity for this talk, which is what the pathway that our patient went down. And so what was that opportunity? I think for our patient, he clearly was hemodynamically dependent upon mechanical circulatory support. And so the LVAD allowed him the hemodynamic support to leave the hospital, to engage with Dr. Azen in addiction medicine, to demonstrate that he could abstain from substances. And with demonstrated sobriety, he became a transplant candidate. But that never would have been possible. He was so acutely ill that never would have been possible without the durable hemodynamic support of the LVAD. I'm not advocating that this should be the approach for everyone. I think as I showed in the pathologic study, methamphetamine-associated heart failure is a spectrum, and we should tailor our management strategies to a patient's ability to recover myocardial function as well as their risk of recidivism. And we are very fortunate at the UW to have a strong addiction medicine program and to work with Dr. Azen in the transplant group and to have those resources available. So I think the specific management strategies for end-stage methamphetamine-associated heart failure really should be tailored to the patient and clinical resources available. Back to our patient, he's doing well. I could show you more months of negative urine toxes, but I won't. He continues to abstain from substances and he continues to see addiction medicine. So takeaways from our last case, the ability to recover myocardial function in methamphetamine-associated heart failure is directly related to the degree of fibrosis on biopsy or LGE on cardiac MRI. LVAD is a feasible hemodynamic strategy to support end-stage methamphetamine-associated heart failure. And in select patients with methamphetamine-associated heart failure, a durable LVAD may be a feasible bridge to opportunity strategy. That's all we have today. Happy to, I think we're right at time, but happy to take any questions about the last case.
Also, quick, when you mentioned LGE, which I think of as replacement.
Yes, there is a study looking at MRI findings in patients with methamphetamine-associated heart failure, and they found, both the presence of LGE and elevated T1 are associated with a worse prognosis. So, I think very few that's why that initial study was so interesting. Is 30 biopsies is in patients with meth-associated heart failure is pretty remarkable, because I think most of these patients do not get endomyocardial biopsies. Yeah. Great. Well, thanks for coming.